Usually when we talk about a medical diagnosis, there's this underlying expectation of precision, I guess. It almost feels like engineering.
Right. It's very binary.
Exactly. Like you break your arm, the x-ray shows that stark, jagged white line across the radius, and the doctor just points at the film and says, well, there it is. That's the problem.
Yeah, the bone is either broken or it's not. We find immense comfort in things that are visible, quantifiable, and easily categorized into neat clinical boxes.
But then you step into the world of neonatal respiratory distress, and suddenly that pristine diagnostic machinery feels like it's short-circuiting. We're looking at a clinical landscape that is honestly just really murky. It relies on sounds, on timing, on like subtle shifts in skin color. So welcome to a very specialized deep dive, tailored specifically for the medical mind.
Which is a fascinating space to explore.
It really is. Whether you are a medical student staring down board exams, or a seasoned professional brushing up on clinical pearls, or, just someone who is deeply fascinated by the intricate and sometimes incredibly fragile architecture of human anatomy, we are so glad you're here with us.
Because our mission today is highly focused and honestly incredibly high stakes. We are constructing a comprehensive clinical guide to the respiratory tract, specifically looking at what happens when things go wrong from the very beginning of life.
Right, at day one.
Exactly. We're going to physically trace the pathway of breath, starting from the upper airway, the nose, and moving anatomically downwards, literally millimeter by millimeter, into the lung parenchyma itself.
And the journey doesn't end at birth, right?
Far from it. We will then explore what happens when that initial structural integrity completely breaks down over time. We'll trace how a microscopic anomaly in infancy can snowball into a chronic, relentlessly destructive condition in adulthood known as bronchiectasis.
Okay, let's unpack this, because we need to establish the reality of these situations. Imagine you are on your first NICU rotation. You're called to the warmer. A newborn is struggling, and the stakes are unimaginably high. Every single second counts here. You are standing there, and you're just listening. You hear a sound. Maybe it's a high-pitched stridor, maybe it's a low rumble of a wheeze.
And identifying the specific nature of that sound, or decoding the exact pattern of feeding difficulty in those first few hours of life, it isn't just an academic exercise to write in a chart.
No, it's everything.
It is the defining factor that dictates your next move. It determines whether that child simply needs to be placed on their stomach, whether they need highly specific and frankly counterintuitive medication, or whether you need to call for a surgical airway immediately to save their life.
It's pure clinical deduction under immense ticking clock pressure. So let's start at the very top, the gateway to the respiratory system. We are looking at the nose, and specifically a condition called choanal atresia.
Yeah, so to understand choanal atresia, we really have to look at the anatomy of the posterior nasal cavity. The choanae are the openings at the very back of the nasal passage that lead into the nasopharynx.
Right, the exit doors of the nose.
Exactly. And in choanal atresia, this critical junction is simply blocked. Structurally, this barrier can be membranous, like a thick, imperforate web of tissue just stretching across the opening, or it can be entirely bony, like an actual solid wall where empty space should be.
Wow.
And it can occur on just one side, which is unilateral, or it can block both sides simultaneously, which is bilateral choanal atresia.
So to picture the mechanics of this, I always think of a scuba diver trying to breathe through a snorkel, but someone has completely capped the end of the tube. For an adult, it's annoying. You just open your mouth. But for a newborn, this is an immediate life-threatening crisis, right? Because infants are obligate nose breathers.
That physiological quirk is so fascinating. Infants just haven't really developed the neurological coordination to consistently breathe through their mouths yet. Anatomically, their epiglottis and soft palate actually overlap.
Oh, to protect the airway during swallowing.
Right.
Yeah.
Which essentially locks them into breathing through their nose.
Yeah.
So when that nasal passage is blocked, they are structurally trapped.
Which brings us directly to the classic clinical triad of choanal atresia. If you are that clinician standing at the warmer, you are hunting for 3 specific signs. First is dyspnea at birth, so obvious, immediate difficulty breathing right out of the gate, with chest retractions and physical struggling.
Yeah, and the second sign is the crucial discriminator here. It's cyclic cyanosis that is specifically associated with feeding.
Okay, break that down for us.
Think about the mechanics of it. When the infant closes their mouth to latch onto a bottle or breast, their only available airway, the mouth is now sealed. The nose is already blocked. So they rapidly run out of oxygen and turn blue. Then, out of desperation, they stop feeding and start crying.
And crying forces the mouth open.
Precisely. They take a massive gasp of air through the mouth while they're crying, and suddenly they pink right back up again.
So blue while feeding, pink while crying.
Yes, that dynamic color change is an absolute siren going off for choanal atresia.
Got it. And the third part of the triad is the physical conformation. You attempt to pass a nasogastric tube, an NGT, through the nostril to the stomach. You advance the tube a few centimeters, and it just hits a hard stop. It absolutely will not pass into the pharynx.
Right, and when you encounter that hard stop, your diagnostic pathway is pretty much set. But you cannot simply focus on the nose here. Embryological defects, they rarely happen in a vacuum.
Because of how everything develops together.
Exactly. Choanal atresia has a massive syndromic connection, most notably with CHARGE syndrome.
Let's break down CHARGE for the medical students meticulously taking notes right now, because this is a classic board exam connection. I remember drilling this.
Yeah, that's a big one. CHARGE is an acronym for a complex constellation of congenital anomalies, and they stem from defects in neural crest cell migration. So C is for coloboma of the eye, which is a missing piece of tissue in the eye structure.
Okay, coloboma.
H is for heart defects, very commonly tetralogy of Fallot, or a VSD. A is the atresia choana we are discussing.
Right.
R is for retardation of growth and development. G stands for genital hypoplasia, and E represents ear anomalies or deafness. So if you diagnose choanal atresia, a full cardiology and genetics workup is absolutely mandatory.
You can't just fix the nose and send them home.
No, absolutely not.
To confirm the specific anatomy of the blockage, you'd order a CT scan of the facial bones, right? Which brilliantly eliminates whether you are dealing with a bony plate or a membranous web. And the treatment is immediate surgical correction to puncture or drill through that barrier and stent the airway open.
Yeah, it's a structural fix for a structural problem. Now, moving anatomically downward from the nasopharynx, we arrive at the larynx, and here we encounter what is arguably the most common anomaly a pediatrician will ever hear, which is laryngomalacia. Literally translated, it means a floppy airway.
It is the undisputed champion of infant respiratory noises. I mean, it's responsible for a staggering 60% of all infant stridor. If you hear a baby making a high-pitched vibrating sound when they breathe in, statistically, laryngomalacia is at the very top of your differential. But what is actually happening physically inside that tiny throat?
It all comes down to structural immaturity. The
Yeah.
cartilage in the supraglottic area, so the structures sitting just above the vocal cords like the epiglottis and the aryepiglottic folds, they lack their normal rigid cellular matrix. There's a profound decrease in laryngeal tone.
So it's just too soft.
Exactly. Now, apply the physics of breathing to this floppy tissue. When the infant takes a breath in, inspiration creates negative pressure inside the airway.
The Bernoulli principle.
It's exactly the Bernoulli principle. Fast-moving air creates low pressure. Because those supraglottic structures are unusually soft, that negative pressure sucks them inward and downward. They physically prolapse into the airway, temporarily narrowing it.
And that rapid vibration of the collapsing tissue against the rushing air, that is what creates the characteristic sound of stridor.
That's the sound, yes.
What's fascinating to me about this is the clinical timeline. Like, parents often say the baby was perfectly quiet in the delivery room. The stridor doesn't typically start on day one.
No, it doesn't. The onset usually occurs within the first 2 to 4 weeks of life. And here is where the clinical picture gets highly stressful for the parents, because the noise actually gets louder and more severe for the first 6 months.
Wait, why does it get worse if the cartilage is supposed to be slowly developing and maturing? That seems backwards.
It does seem backwards, but it's because the infant is growing stronger. At 1 month old, their diaphragmatic excursion is relatively weak, but by 4 or 5 months, they are generating much more forceful inspirations. Stronger breaths mean greater negative pressure, which means a more violent collapse of that floppy tissue.
Oh, wow.
Yeah, so the stridor peaks right around 6 months.
That has to be absolutely terrifying for a parent. You bring your new baby home, and every week they sound like they're struggling more and more to pull air in.
It requires immense reassurance from the physician. We have to really educate the parents on the natural history of the disease. After that 6-month peak, the cellular maturation of the cartilage finally catches up. The structures stiffen, the prolapse stops, and there's a gradual resolution of symptoms.
Usually completely gone by when?
Typically completely resolving by 18 to 24 months of age.
Okay, I want to push back on the reassurance aspect for a moment, though. If I have a 3-month-old infant in front of me making a horrific inspiratory noise, how do I confidently differentiate a benign, self-resolving laryngomalacia from something sinister that needs an operating room immediately?
That is the crux of pediatric airway management right there. You have to evaluate the entire patient, not just the noise. You are looking for a child who is otherwise thriving. Their cry is completely normal and strong.
Which tells us the vocal cords themselves, sitting below the floppy tissue, are functioning perfectly.
Precisely. You also meticulously chart their growth curve. Are they gaining weight appropriately? Furthermore, you test the physical mechanics of the stridor. With laryngomalacia, the stridor crucially worsens when the infant is supine lying flat on their back.
Because gravity pulls it down.
Yes, gravity pulls those floppy supraglottic tissues down, which exacerbates the obstruction. When you place them prone or upright, the noise often improves significantly.
Okay, so if they have a normal cry, they're gaining weight, and the sound changes with position, we can feel pretty comfortable observing them.
Usually, yes. A definitive diagnosis is made via awake flexible laryngoscopy in the clinic, where the ENT can literally watch the tissue prolapse during inspiration. But we also remain vigilant for complications. Because breathing requires so much effort, these infants have poor suck, swallow, breathe coordination.
Which leads to feeding issues.
Exactly. Profound feeding difficulties.
I'd imagine gastroesophageal reflux plays a role here too, right?
A massive role. Think about it. The severe negative intrathoracic pressure generated to overcome that floppy airway acts like a vacuum. It literally sucks acidic stomach contents up into the esophagus and pharynx.
Ugh. And that acid just bathes the already inflamed floppy laryngeal tissues.
Exactly, causing further swelling and making the stridor even worse. So treating concurrent GERD aggressively is actually a cornerstone of managing laryngomalacia.
What is the tipping point where observation is no longer ethical, though? When do we actually intervene surgically?
We operate when the anatomical defect begins to cause systemic failure. If the patient develops progressive, severe respiratory distress resulting in cyanotic episodes, or if they develop cor pulmonale from chronic hypoxia, we intervene. But the most common surgical trigger is failure to thrive.
Because they're working so hard to breathe.
Right. If an infant is burning so many calories just trying to pull air past their floppy larynx that they cannot gain weight, they are essentially starving.
The calorie math just doesn't work out.
Exactly. At that point, an ENT will perform a supraglottoplasty, which is a microscopic surgical procedure to trim away the excess floppy aryepiglottic folds and stabilize the airway.
Okay, so if the issue isn't the supraglottic tissue, we keep our clinical flashlight moving downward. We pass the vocal cords and enter the subglottic space. This brings us to congenital subglottic stenosis, which is the second most common cause of infant stridor.
And we are now dealing with a fundamentally different mechanical problem here. We aren't looking at floppy tissue anymore. We're looking at a fixed, rigid narrowing of the airway. The subglottis is entirely encased by the cricoid cartilage. It's the only complete 360-degree cartilaginous ring in the entire respiratory tract.
Which means it has zero capacity to expand. If there's swelling or structural deformity inside that ring, the airway simply shrinks, and it can't give it all.
Precisely. Congenital stenosis can occur if the cricoid cartilage itself forms in an abnormally small or elliptical shape during embryogenesis. Another structural cause is a trapped tracheal ring.
What does that mean?
It's where the first ring of the trachea slips upward and becomes physically wedged inside the cricoid cartilage. It doubles the thickness of the wall and halves the lumen. Alternatively, it might be soft tissue thickening inside the ring caused by ductal cysts or submucosal gland hyperplasia.
The sound changes significantly here, doesn't it? We mentioned laryngomalacia is primarily an inspiratory noise.
That is a vital acoustic clue. Because subglottic stenosis is a fixed, unchanging narrowing, it impedes airflow in both directions. Therefore, it typically causes a biphasic stridor.
Biphasic, meaning both ways.
Yes, you hear the high-pitched restriction both when the infant breathes in and when they breathe out.
You specified congenital subglottic stenosis. In a real-world clinical setting, especially in a child who has been in the hospital, how do we differentiate congenital from acquired stenosis?
The clinical history tells the entire story there. Acquired subglottic stenosis is overwhelmingly iatrogenic, meaning it's a consequence of medical intervention. We see this frequently in premature infants who required prolonged endotracheal intubation in the NICU.
So the breathing tube itself causes the damage.
Yes, unfortunately. The endotracheal tube rests directly against the mucosa inside that cricoid ring. Over weeks of mechanical ventilation, the pressure of the tube causes mucosal ischemia. The tissue loses its blood supply, necroses, and ulcerates.
And then it scars.
Exactly. When the body tries to heal that ulceration, it lays down thick, fibrous scar tissue. That scar tissue contracts, creating a dense, acquired stricture.
To diagnose either form, congenital, or acquired, we have to look directly at the area with rigid bronchoscopy, right? And if the narrowing is severe, the surgical fixes sound incredibly delicate.
They are. If the stenosis narrows the airway by more than 50% and the child is failing extubation or failing to thrive, we move to surgery to avoid a permanent tracheostomy. For milder cases, an anterior cricoid split is performed. The surgeon literally cuts the cricoid ring anteriorly to allow it to sort of spring open and widen.
Wow.
For severe cases, a laryngotracheal reconstruction is required, where pieces of the child's own rib cartilage are harvested and grafted into the airway to physically expand its diameter.
That is just astonishing structural engineering. Let's move back up just a millimeter to the vocal cords themselves. Vocal cord paralysis is the third most common congenital laryngeal anomaly.
And while it produces stridor, the underlying pathophysiology is entirely different from malacia or stenosis. We aren't dealing with a structural blockage. We are dealing with a profound neurological or muscular failure. The doors to the airway simply refuse to open.
Right. I always visualize the vocal cords as a set of heavy double doors in a hallway. When you breathe, both doors should swing wide open against the walls, creating a wide open corridor for air. When you speak or swallow, they should slam tightly shut together.
That's a great visual.
If they lose their nervous system signal, they just hang loosely in the middle of the hallway. Air can't get past them cleanly, and dangerously, food and liquid can easily slip between them and fall straight into the lungs.
That analogy perfectly captures the dual danger of paralysis, which is airway obstruction and aspiration. We categorize this clinically into unilateral paralysis. So one door is paralyzed versus bilateral paralysis, where both doors are completely offline, and the clinical presentations are starkly different.
Unilateral paralysis is fascinating to me because it's often a story of collateral damage.
It is predominantly an acquired iatrogenic injury. To understand why, you really have to trace the anatomical path of the recurrent laryngeal nerve, which controls the vocal cords. Instead of taking a direct route from the brain to the larynx, the left recurrent laryngeal nerve plunges deep down into the chest cavity, loops underneath the arch of the aorta, and then travels all the way back up the neck to the larynx.
It's like a fishing line that got snagged on a pipe deep in the basement.
Exactly. That incredibly long circuitous route makes it incredibly vulnerable. We frequently see unilateral paralysis following pediatric cardiothoracic surgeries. For instance, during the surgical ligation of a patent ductus arteriosus, or PDA, the surgeon is working millimeters away from where that nerve loops around the aorta. The repair of a tracheoesophageal fistula also puts the nerve at immense risk.
Clinically, what does a baby with one paralyzed cord look like? I mean, do they have stridor?
Because one cord is still functioning and opening, their airway is usually sufficient, so they might only have mild stridor. But because the paralyzed cord hangs in the midline, the functioning cord can't meet it properly to form a seal.
Right.
Therefore, the infant presents with a noticeably weak, breathy cry. More concerningly, they will have episodes of coughing and choking during feeds because that imperfect seal allows microaspiration of milk right into the trachea.
No, bilateral vocal cord paralysis is a much more ominous clinical picture.
It is a neonatal emergency. Bilateral paralysis is rarely a surgical complication. It is much more deeply rooted in congenital central nervous system pathology. We are looking for lesions originating in the brainstem or the upper spinal cord where the vagus nerve nuclei live.
So we are hunting for major neurological defects at this point.
Exactly. We frequently see bilateral paralysis in infants with Chiari malformations, which is where the cerebellar tonsils herniate downward through the foramen magnum and physically compress the brainstem. It's also associated with severe hydrocephalus and myelomeningocele.
If both doors are stuck near the midline, the presentation has to be severe.
The infant will exhibit high-pitched, severe inspiratory stridor with significant respiratory distress immediately after birth. Because neither cord can move to vibrate or seal, their voice will be intensely hoarse, or they may exhibit complete aphonia.
Aphonia, so an inability to produce any sound at all.
Yes, and the risk of massive recurrent aspiration pneumonia is exceptionally high.
Diagnosis relies on awake, flexible laryngoscopy. The ENT needs to see the cords in action, or rather, failing to act. What are the specific visual findings they document?
They look for 4 classic signs. First, immobility. The vocal fold simply does not abduct or open when the infant attempts to take a deep breath. Second, incomplete glottal closure. When the child cries, the cords fail to meet tightly in the midline, leaving a visible glottic gap.
The doors won't shut.
Right. Third is bowing. Over time, the denervated muscle of the paralyzed vocal fold atrophies and loses its tone, causing the edge of the cord to bat outward like a slack sail.
Oh, interesting.
And finally, they look for shortened length and anterior arytenoid rotation. The arytenoid cartilage, which the cord attaches to at the back, loses its stabilizing muscle pull and kips forward, making the paralyzed cord appear physically shorter.
For unilateral paralysis, the nerve often recovers on its own, and the paralysis can resolve spontaneously within 6 to 12 months. But for bilateral, it sounds like securing the airway is the only viable option.
Yes, for bilateral paralysis, a temporary surgical tracheotomy is almost always required to provide a safe, secure airway while the underlying neurological conditions are investigated and managed by neurosurgery.
Before we descend into the chest, we need to touch on congenital laryngeal webs and atresia.
These are rare, but they represent a failure of the embryological airway to recanalize or essentially hollow out around the 10th week of gestation. A web is a sheet of tissue stretching across the glottis, essentially fusing the vocal cords together.
Here's where the clinical genetics get really fascinating. This isn't just an isolated webbing.
No, there is a profound syndromic association here, specifically with chromosome 22q11.2 deletion syndrome, which is also known as DiGeorge syndrome. If you find a laryngeal web, you must immediately screen the infant for concurrent cardiovascular anomalies, like an interrupted aortic arch or truncus arteriosus, as well as hypocalcemia and immune deficiencies.
The presentation depends on how much of the airway the web covers, right? Ranging from a weak cry to complete respiratory failure requiring immediate intubation, or a surgical airway if it's a complete atresia.
Exactly. It spans the whole spectrum.
Let's take a breath, literally. We have navigated the nose and the complex machinery of the larynx. But as our clinical flashlight moves deeper into the chest cavity, into the tracheobronchial tree, the acoustic landscape shifts entirely. The high-pitched vibrating stridor fades away, and we start hearing the low-pitched whistling rumble of wheezing. And this requires a massive shift in how a clinician processes the diagnosis.
It does. We are crossing a physiological boundary. We are now talking about tracheomalacia and bronchomalacia. Conceptually, it shares similarities with laryngomalacia. It is a structural abnormality defined by excessive collapsibility. But instead of floppy supraglottic tissue, we are dealing with a failure of the heavy cartilaginous rings that form the trachea and the mainstem bronchi. They fail to hold the airway open under pressure.
Pathologically, we divide this into primary and secondary causes. Primary malacia feels like a manufacturing defect of the cartilage itself.
That's a really good way to frame it. In primary tracheomalacia, there is an intrinsic developmental defect in the cartilage rings. The ratio of cartilage to membranous tissue is altered, making the rings unusually soft and compliant. We see this frequently in premature infants whose cartilage hasn't fully matured, but it's crucial to note that the absolute majority of clinically significant cases are actually diagnosed in term infants.
And secondary malacia, that's where the cartilage is normal, but it's being attacked from the outside, right?
Precisely. Secondary malacia implies extrinsic compression. The central airways is being physically crushed by an adjacent anatomical structure. The most famous example is a vascular ring.
Right.
Imagine an abnormally routed blood vessel, like a double aortic arch, forming a tight loop completely around the trachea. Every time the heart beats, that vessel pulsates and physically compresses the tracheal cartilage, eventually softening it and causing it to collapse.
You can also see secondary malacia in kids who had a tracheoesophageal fistula repaired, right?
Yes, very often. The embryological error that created the fistula often results in a concurrent, localized defect in the tracheal cartilage rings right at the site of the abnormal connection.
Let's dive into the clinical presentation, because this is where the trap lies for the unwary clinician. The hallmark sound is wheezing, but it's a very specific type of wheeze. It's a low-pitched monophonic wheeze heard predominantly during expiration, and it's loudest over the central chest, not the periphery.
Every single word of that description matters. Monophonic means a single, continuous musical tone. It sounds like blowing over the mouth of a glass bottle.
Okay, I can hear that.
This indicates a single, large central airway is collapsing. Compare that to the classic polyphonic wheeze of asthma, which sounds like a discordant symphony of high and low notes because thousands of tiny peripheral airways are all constricting at different rates.
The other key feature is what you don't see.
Exactly. In pure tracheomalacia, because the obstruction is central, you do not typically see hyperinflation of the chest on an X-ray, nor do you see the severe subcostal retractions, the pulling in of the belly muscles, that characterize a severe asthma attack.
Okay, here is the diagnostic trap. Put yourself in a busy pediatric ER. It's 2 a.m. A child is brought in struggling to breathe, and you put your stethoscope on their chest and hear a loud wheeze. An instinct drilled into every medical professional, is to immediately order a nebulized bronchodilator, albuterol, a beta agonist. Why is that an incredibly dangerous reflex in this specific scenario?
This is a vital, potentially life-saving pharmacological distinction. Beta-adrenergic agents, like albuterol, are absolutely contraindicated in pure tracheomalacia or bronchomalacia.
Wait, a child is wheezing and struggling to breathe, and I shouldn't give them the universal airway opening drug. Explain the cellular mechanics of why that is bad.
We have to look at what albuterol actually does. Beta agonists target smooth muscle receptors. Their entire job is to force smooth muscle to relax. In asthma, the airway is narrowed because the smooth muscle is violently spasming and constricting. Relaxing that muscle opens the pipe. It's a lifesaver.
But in Malaysia, the smooth muscle isn't the villain. The cartilage is.
Exactly. In tracheomalacia, the cartilage rings are weak and floppy. The only thing keeping that airway from entirely collapsing flat during expiration is the baseline resting tone of the tracheal smooth muscle. That muscle tone is acting like an internal splint.
So if you give albuterol,
You relax the smooth muscle. You wipe out the last remaining structural support the airway had. The floppy cartilage is now completely unsupported, and a collapsibility of the airway dramatically increases. You can take a child with a noisy but functioning airway and literally push them into acute respiratory failure by following a standard asthma protocol.
that is an incredible, terrifying clinical reality. The medication designed to open the airway physically collapses it.
It really highlights why distinguishing a central monophonic wheeze without hyperinflation from a peripheral polyphonic wheeze is paramount. Now, the frustrating clinical reality is that a child can have concurrent asthma or viral bronchiolitis alongside their malacia.
Oh, so they have both going on.
Right. If they have both, the peripheral airways are tight and hyperinflated, which muddies the waters. But for pure structural malacia, beta agonists cause harm.
So if I'm holding an empty albuterol nebulizer, what is the proper management? How do I help this child breathe?
We use a different pharmacological approach. Nebulized ipratropium bromide is often utilized. It's an anticholinergic medication. It helps dry up secretions and, crucially, it doesn't cause that profound relaxation of the necessary smooth muscle tone.
But mostly it sounds like a mechanical management issue.
Yeah, it is deeply mechanical. These floppy airways cannot efficiently clear mucus. A normal cough relies on the airway narrowing slightly to increase the velocity of air, like putting your thumb over a garden hose.
Right.
But in malacia, coughing causes the airway to collapse completely, trapping the mucus behind a closed door. Therefore, we rely heavily on intensive chest physiotherapy and postural drainage to manually mobilize secretions.
And for the severe cases, the infants who are literally turning blue.
For infants experiencing life-threatening cyanotic spells, which involve apnea, profound cyanosis, and severe bradycardia, as the vagus nerve is stimulated by the collapsing airway, we must intervene mechanically. We often use CPAP, continuous positive airway pressure.
Pneumatic stenting.
Precisely. By forcing pressurized air into the lungs continuously, we use a column of air to physically hold the floppy trachea open from the inside. In extreme cases, a permanent tracheostomy is placed to deliver that CPAP or customized endobronchial stents are deployed to physically hold the cartilage open.
Is there a surgical fix? Can you rebuild a floppy trachea?
Surgery is rarely the primary approach for primary malacia. However, if the collapse is secondary to a vascular ring, thoracic surgery to divide that abnormal blood vessel and relieve the external compression is curative. This is why definitive diagnosis requires advanced imaging.
You want to map the blood vessels.
An MRI with angiography is the gold standard when you suspect a vascular anomaly. It will brilliantly map the aortic arch and any aberrant vessels wrapping around the airway. Definitive diagnosis of the malacia itself requires dynamic, flexible bronchoscopy. The pulmonologist watches the airway in real time as the child breathes, quantifying exactly how much the trachea collapses during forced expiration.
We have spent a lot of time in the pipes, the nasal passages, the larynx, the trachea. But what happens when the actual destination of all this air, the lung tissue, the alveolar beds where gas exchange actually occurs, fails to construct itself correctly in utero?
This brings us to parenchymal defects. And the most extreme, profound examples of this developmental failure are pulmonary genesis, aplasia, and hypoplasia.
Pathologists define these terms with rigorous precision. They sound similar, but they describe entirely different anatomical realities. Agenesis means absolute, complete absence. There is no lung tissue, no bronchus, and no pulmonary blood supply. It's just an empty space in the chest.
Correct. Aplasia, on the other hand, means the development started but aborted very early. There is a rudimentary blind-ending pouch of a main bronchus, but absolutely no lung tissue and no pulmonary artery beyond that dead end.
And hypoplasia.
Hypoplasia implies the lung is present, but it is fundamentally underdeveloped. There is a dramatic decrease in both the number of microscopic alveoli and the branching airway generations. It's a miniaturized, inadequate lung.
Let's confront the clinical reality of these defects. Bilateral pulmonary agenesis, a fetus developing with absolutely no lungs, is tragically incompatible with life. The infant will experience immediate irrecoverable respiratory failure the moment the umbilical cord is cut. But unilateral agenesis missing just one lung is a completely different physiological story.
It is. It is thought to be an autosomal recessive trait, occurring in roughly 1 in 10,000 to 15,000 live births. And human physiology is remarkably adaptable. An infant can survive with only one lung.
How does the body compensate for missing 50% of its gas exchange capacity from day one?
The remaining solitary lung undergoes profound compensatory growth. The alveoli multiply and physically expand. Because half of the chest cavity is literally empty, the remaining lung hyperexpands across the midline, filling that void to maximize its surface area for oxygen exchange.
But nature abhors a vacuum. That massive shift has to cause structural chaos.
It causes a profound mediastinal shift. The heart, the trachea, the esophagus, everything is pulled aggressively toward the empty side of the chest. Over time, this massive asymmetrical tension on the developing skeleton leads to severe progressive scoliosis. And ironically, the hyperexpanded good lung can eventually compress its own airway against the spinal column.
And as we've seen a theme emerging today, this missing lung is rarely an isolated bit of bad luck.
No, pulmonary agenesis is deeply intertwined with broader errors in embryogenesis. It is frequently identified as a component of the Vactral association.
Let's explicitly define that for the students. What are we systematically checking for if we suspect Vactral?
Vactral is a non-random association of birth defects. V stands for vertebral anomalies, typically missing or misshapen spinal bones. A is for anal atresia. C represents severe congenital heart disease.
Okay, VAC.
TE is for tracheoesophageal fistula, an abnormal connection between the windpipe and stomach tube. R is renal anomalies, like absent or horseshoe kidneys. And L stands for limb anomalies, particularly missing or deformed radius bones in the arms. If a child is missing a lung, every single one of those organ systems requires immediate, thorough investigation.
I want to highlight a massive, potentially fatal clinical pitfall here regarding aplasia. Imagine that infant arrives in the ER with unilateral wheezing and respiratory distress. You order a stat chest x-ray. The image shows a completely opaque, collapsed lung on one side and a massive shift of the heart and trachea pulling toward that darkness. To 90% of clinicians, that specific x-ray presentation screams one diagnosis, which is a swallowed foreign body.
Yes, it perfectly mimics a toddler who has inhaled a peanut or a piece of Lego that is now completely occluding the right main bronchus, causing the lung behind it to collapse and the vacuum to pull the mediastinum over.
And the gold standard, urgent intervention for a foreign body aspiration is to take the child to the OR, insert a heavy, rigid bronchoscope down the airway, and extract the object.
But consider the anatomy of pulmonary aplasia. The X-ray looks identical, but there is no peanut. The main bronchus simply ends in a very short, incredibly delicate, rudimentary blind pouch.
So if a surgeon goes in aggressively with a rigid bronchoscope, pushing hard, expecting to pop past a piece of plastic,
They will ram that rigid metal scope directly through the fragile wall of the blind pouch. This causes a catastrophic, often fatal perforation into the mediastinum, leading to massive hemorrhage and tension pneumomediastinum.
it's a terrifying scenario.
Which is exactly why maintaining a high index of suspicion for congenital anomalies is mandatory. You must pause and consider the patient's history. Is this a sudden onset in a toddler eating peanuts, or a neonate with a history of feeding issues?
Context is everything.
To avoid this fatal trap, a high-resolution CT of the chest with contrast is the definitive diagnostic tool. It will clearly visualize the absence of lung parenchyma and precisely define that blind-ending bronchus without ever putting a physical scope near the patient's airway.
Incredible. It's a testament to letting the imaging guide the intervention. Let's examine another parenchymal malformation. Congenital pulmonary airway malformation, or CPAM.
Historically, you may see this referred to in older literature as cystic adenomatoid malformation. CPAM is a fascinating, complex pathology. It consists of a mass of hematomatous or dysplastic, completely disorganized lung tissue that is intricately mixed with normal lung parenchyma. It usually confines itself to a single lobe of the lung, occurring in about 1 to 4 per 100,000 births.
Radiologists categorize it based on the size of the cysts, right? Macrocystic, with
Yeah.
massive cysts larger than 5 millimeters, or microcystic, which looks more solid. But the embryological timeline is what truly dictates the architecture of this lesion.
Yes, the exact trigger is unknown, but we know CPAM is the result of a very specific, localized embryological injury occurring before the 35th day of gestation. At this microscopic stage, an insult derails the normal branching of the terminal bronchioles. Instead of forming elegant, functional alveolar sacs, the tissue proliferates wildly into glandular elements and disorganized cysts lined with respiratory epithelium. It creates a space-occupying mass that has zero capability for gas exchange.
And there's a fascinating histological clue about the exact timing. Pathologists look for cartilage inside the tumor.
Yes, in the vast majority of CPAMs, cartilage is completely absent. However, if a pathologist dissects the resected lobe and discovers mature cartilage rings within the dysplastic mass, it fundamentally rewrites the timeline. It strongly indicates that the embryologic insult didn't happen on day 35, but occurred much later in fetal development, extending into the 10th to 24th week of gestation, which is the specific window when bronchial cartilage is actively forming.
Clinically, how does a massive cystic non-functional tissue present?
It spans an immense spectrum. On the most severe end, large microcystic lesions can compress the fetal heart in utero, preventing venous return and causing massive fetal heart failure, known as hydropsophilia. This often leads to fetal demise.
Right.
In the neonatal period, it presents as severe respiratory distress as the cysts expand with air but don't deflate, crushing the adjacent healthy lung tissue.
But on the other end of the spectrum, the literature describes patients who are completely asymptomatic. Like a small lesion might sit quietly in the lung until the child is 7 or 8 years old, and it only gets discovered because the kid keeps getting pneumonia in the exact same lower left lobe over and over again.
Because those cysts don't have normal ciliary clearance, they become stagnant ponds for bacteria. On examination of a symptomatic child, you will note dramatically decreased breath sounds over the affected lobe. The chest X-ray will reveal a complex cystic mass, often with a mediastinal shift. Crucially, if the cyst is infected, you will see an air fluid level inside it, which can perfectly mimic a lung abscess.
This leads to a fascinating clinical dilemma. If you diagnose a small CPAM in a 6-month-old infant, and that infant is completely asymptomatic, they are breathing perfectly, gaining weight, smiling, why do pediatric surgeons strongly advocate for taking them to the operating room and surgically removing a lobe of their lung?
It's a question of weighing future catastrophic risk against current surgical risk. We do not leave asymptomatic CPAMs alone because that dysplastic, disorganized tissue harbors a deeply sinister potential. Pathologists have extensively documented that CPAMs can undergo malignant transformation. There is a highly specific risk of sarcomatous degeneration, specifically pleural pulmonary blastoma and carcinomatous degeneration later in life.
The tissue is genetically unstable, so it is basically a ticking clock for cancer.
Precisely. Therefore, the standard of care is prophylactic surgical resection. We typically wait until the infant is between 6 and 12 months of age to allow them to grow and better tolerate anesthesia, but the lobectomy is performed to definitively eliminate that risk of future malignancy. The surgical mortality is low, less than 10%, which entirely justifies removing the precancerous tissue.
Moving from disorganized tissue to something that sounds genuinely like it belongs in a science fiction novel. Pulmonary sequestration.
It is one of the most bizarre anomalies in pulmonary medicine.
Yeah.
A pulmonary sequestration is a solid, non-functional mass of lung tissue that has absolutely, unequivocally zero connection to the normal tracheobronchial tree.
It's a rogue organ. It decided to build its own private infrastructure completely off the grid from the rest of the body's respiratory system.
This is exactly what it does. Because it lacks any physical connection to the bronchi, no air can enter it. It does not participate in gas exchange. But what truly defines a sequestration is its vascular supply.
Okay, tell us about that.
It does not receive low-pressure, deoxygenated blood from the pulmonary artery like the rest of the lung. Instead, it parasitizes a high-pressure blood supply. It is fed by a massive, aberrant systemic artery that typically branches directly off the descending thoracic aorta.
It tapped into the main power line. We differentiate these into intrapulmonary wrapped inside the normal lung's visceral pleura and extrapulmonary wrapped in its own separate pleural sac. But clinically, how do you even detect a piece of lung that isn't connected to the airways?
It acts purely as a space-occupying lesion. The infant might exhibit respiratory distress simply because this solid mass of rogue tissue is taking up valuable real estate in the chest cavity. On a physical exam, if you percuss the chest, you'll hear a dull thud over the mass instead of normal resonance, and breath sounds will be entirely absent in that specific spot.
But there's a unique cardiovascular tell, isn't there? A sound you wouldn't expect to hear when listening to the lungs.
Yes, and it's a phenomenal clinical pearl. Remember that aberrant systemic artery feeding the mass. It is pulling blood directly from the aorta at high systemic pressures, perhaps 100 millimeters of mercury, and dumping it into this low-resistance mass of tissue. The turbulence of that high-pressure blood flow is immense.
So you can actually hear it.
If you place your stethoscope over the patient's back, right over the sequestration, you can frequently auscultate a loud, continuous, or purely systolic murmur.
You hear a vascular murmur on the back, and you immediately suspect a lung mass. That is elegant diagnostics.
It is. Now, complications arise if that rogue tissue becomes infected. How does a sealed mass get infected? Usually, the intense inflammation from a nearby pneumonia in the normal lung breaks down the barrier, and bacteria leak into the sequestration. Once inside, they flourish, creating recurrent, deep-seated infections.
To diagnose it, we need advanced imaging.
A CT scan with intravenous contrast is mandatory. It will not only characterize the dense mass of tissue, but the contrast will brilliantly illuminate that aberrant systemic artery originating from the aorta. MR angiography is also exquisite for mapping this bizarre vascular anatomy.
And treatment is surgical removal, but the surgeon has to be hypervigilant here, right?
Surgical resection of the sequestered lobe is curative, but the operation carries a unique, terrifying risk. If the surgeon approaches the mass thinking it's a typical lung resection and inadvertently severs that aberrant artery before clamping it, the vessel, which is under high aortic pressure, will retract deep into the mediastinum or abdomen and cause massive, catastrophic, uncontrollable hemorrhage. The surgeon must painstakingly identify, ligate, and secure that aberrant systemic artery before touching the mass itself.
Before we pivot away from these congenital space-occupying lesions, let's briefly detail bronchogenic cysts.
A bronchogenic cyst is an embryological remnant. It results from an abnormal budding of the foregut very early in fetal development, typically before the 16th week of gestation. This tiny bud pinches off and forms a closed, fluid-filled sac lined with respiratory epithelium, complete with ciliated cells and mucus glands.
They usually locate themselves right in the midline of the chest, hovering near the trachea or the carina where the main bronchi split. And because they are closed sacs, they don't cause problems by doing anything, they cause problems simply by expanding and pushing on things.
Exactly. As the cells inside the cyst secrete mucus, the cyst slowly inflates like a water balloon. Eventually, it exerts external pressure on an adjacent central airway. This brings us back to our earlier discussion. External compression causes secondary localized tracheomalacia, presenting clinically with wheezing and persistent cough.
And they are highly prone to infection.
Very much so. The most common presentation in older children or adults is a sudden onset of fever, chest pain, and a productive cough when the cyst itself becomes acutely infected. In rare cases, if the cyst expands posteriorly, it can physically compress the esophagus against the spine, causing dysphagia or severe difficulty swallowing solid food.
A chest x-ray might show a smooth, round mass in the mediastinum. If it's infected and has established a tiny microconnection to an airway, you'll see an air fluid level. CT or MRI definitively defines its relationship to the surrounding anatomy. What is the management strategy?
Symptomatic cysts must be surgically excised, generally after a course of antibiotics to cool down the acute inflammation. But critically, even if a bronchogenic cyst is discovered incidentally on a scan and the patient is completely asymptomatic, surgical excision is highly recommended. The risk of these cysts eventually becoming infected, expanding, and causing severe airway compromise is simply too high to leave them in the chest.
We have covered an incredible amount of anatomical ground regarding congenital structural defects. We've explored the membranous blockages, the floppy cartilage, the missing lobes, and the rogue tissues. But if we pull back and look at the larger clinical timeline, all of these seemingly disparate congenital defects share a common, dangerous downstream effect.
They do.
Whether they cause pooling of mucus in a cyst, or failure to clear secretions due to floppy cartilage, or repeated pneumonias due to aspiration, they all set the stage for chronic, unrelenting inflammation in the airway.
They create the perfect storm. And chronic inflammation in the delicate respiratory mucosa is not a benign state. Over years and decades, that constant state of inflammatory war causes profound, irreversible structural damage to the architecture of the lung.
Which transitions us directly into the final major topic of this deep dive. We are moving from congenital defects to the acquired structural nightmare that often follows them, bronchiectasis.
Bronchiectasis is a defining endpoint of chronic lung disease. It is defined pathologically as an abnormal, permanent dilatation of the bronchi. The critical word there is permanent. The airway has been irreversibly destroyed.
It's never going back to normal.
No. The disease can be focal, localized to a single lobe, perhaps where a foreign body was lodged for years, or it can be diffuse, destroying airways across both lungs simultaneously. But the fundamental driving mechanism is the impaired drainage of bronchial secretions.
Let's investigate the etiology. What are the specific risk factors and usual suspects that initiate this destruction?
The clinical history of a bronchiectasis patient usually reads like a long, arduous list of pulmonary insults. Cystic fibrosis is overwhelmingly the most common cause of severe diffuse bronchiectasis in developed nations. The thick, dehydrated mucus intrinsic to CF traps bacteria relentlessly. We also look closely at immunodeficiency syndromes, such as common variable immunodeficiency or severe combined immunodeficiency. If the patient's immune system cannot clear common environmental pathogens, those pathogens set up permanent residence in the lungs.
There's also primary ciliary dyskinesia, or PCD.
Yes, in PCD, the microscopic cilia, the tiny beating hairs that line the respiratory tract and constantly sweep mucus upward towards the throat, are structurally defective. They are paralyzed or beat uncoordinatedly. Without that mucociliary escalator, mucus pools statically in the lower airways, inviting infection.
Historically, and still today, in areas with lower vaccination rates, childhood infections play a massive role.
A single severe episode of whooping cough caused by Bordetella pertussis or a severe bout of the measles virus in childhood can cause enough intense necrotizing damage to the bronchial walls to initiate the bronchiectatic process. Similarly, specific bacterial pneumonias that literally eat away at the tissue like Staphylococcus aureus, Klebsiella pneumonia, and of course Mycobacterium tuberculosis are profound triggers. Adenovirus and severe influenza can also cause permanent structural scarring.
Beyond infections, we have to consider mechanical obstructions.
Always. An unrecognized, retained foreign body like a small bead inhaled at age 3 and never removed will cause chronic, intense, localized inflammation and eventually focal bronchiectasis in that specific segment. Extrinsic compression from enlarged, calcified lymph nodes pressing on a bronchus can do the same. There are also rare systemic conditions linked to it, such as yellow nail syndrome, which involve lymphedema and pleural effusions.
I want to spend significant time on the pathophysiology here. The literature refers to this as a vicious cycle. Walk us through the exact cellular cascade of this loop. How do we go from a localized pneumonia to permanently balloon-destroyed airways?
It is a devastating feedback loop of the body's own making. It begins with an initial insult, a viral infection, an aspirated peanut, or a failure to clear normal mucus. This trigger leads to bacterial colonization. The presence of bacteria triggers a massive, acute inflammatory response. The immune system sounds the alarm, rapidly recruiting millions of inflammatory cells, primarily neutrophils, into the airway lumen to fight the invaders.
So far, that sounds perfectly normal. Neutrophils are the first responders. We want them there to kill the bacteria.
We do. But in bronchiectasis, the inflammatory response becomes entirely dysregulated. It fails to shut off. These recruited neutrophils are armed with powerful chemical weapons meant to destroy bacterial cell walls. They release a flood of inflammatory cytokines, peroxidases, and highly destructive enzymes. The most critical villain in this story is an enzyme called neutrophil elastase, along with matrix metalloproteinases.
What exactly does neutrophil elastase do?
In a healthy, brief inflammatory response, it helps break down cellular debris for cleanup. But in this chronic, hyper-concentrated state, there is a massive upregulation of elastase, and this enzyme does not discriminate. It begins to digest the fundamental structural components of the patient's own airway wall.
Oh, wow.
It literally dissolves the elastin, the smooth muscle fibers, and the solid cartilage rings that give the bronchus its rigid shape and tone.
It's molecular-friendly fire. The immune system is eating the lung.
Exactly. That is the destruction phase. The beautifully engineered muscular cartilaginous airway wall is liquefied and replaced by stiff, non-functional fibrous scar tissue. Because the airway has completely lost its muscular tone and its elastic recoil, the rubber bands that hold it tight It permanently dilates. It balloons outward under the pressure of breathing.
And a ballooned airway is a useless airway.
It leads to a profound loss of ventilatory function. But more importantly, the extreme dilation physically destroys the mucociliary escalator. The cilia are gone, and the airway is too wide to effectively squeeze mucus upward during a cough.
So now you have these wide, floppy, scarred tunnels.
Yes, and because they cannot drain, these dilated airways become filled with stagnant, deep pools of thick, highly purulent material, a toxic sludge of mucus, dead bacteria, and millions of dead neutrophils. The smaller peripheral airways distal to the dilation often become completely occluded by this sludge, or they obliterate entirely, replaced by solid scar tissue.
And here's where the loop closes and starts again, because that toxic sludge is just sitting there.
It becomes the perfect, warm, nutrient-rich breeding ground. Bacteria colonize these stagnant pools. Crucially, pathogens like Pseudomonas aeruginosa recognize this static environment and form incredibly resilient biofilms, thick, slimy shields that protect the bacterial colonies from both the patient's immune cells and our intravenous antibiotics.
Which just brings the neutrophils right back.
This massive bacterial load triggers the immune system again. It recruits a fresh wave of neutrophils, which release more elastase, which dissolves more cartilage, which widens the airway further, allowing more mucus to pool. The cycle spirals endlessly downward.
That is a terrifying, inescapable feedback loop. Now, here's where the pathology creates one of the most alarming symptoms in all of medicine. Patients with advanced bronchiectasis frequently experience hemoptysis, coughing up massive amounts of bright red blood. It can be fatal. Why does a disease of mucus and floppy airways cause such violent bleeding?
It's an ingenious, albeit ultimately destructive, physiological adaptation by the body. The lung tissue is constantly inflamed, hypoxic, and dying. In a desperate attempt to heal the area and deliver more oxygen and immune cells, the body triggers massive angiogenesis, the creation of new blood vessels. It specifically hypertrophies the bronchial arteries.
To clarify the anatomy, the lungs have two blood supplies. The pulmonary arteries carry low-pressure, oxygen-poor blood to be oxygenated. But the bronchial arteries are systemic. They branch right off the aorta. They carry oxygen-rich blood at high systemic blood pressure to feed the actual lung tissue.
Exactly. And under the influence of chronic inflammation, these high-pressure bronchial arteries become massively enlarged, tortuous, and engorged. They bulk up tremendously, but it gets worse. As the inflammation destroys the tissue barriers, abnormal anastomosis direct physical connections form between this high-pressure bronchial arterial circulation and the much lower-pressure pulmonary arterial circulation.
You're directly connecting a high-pressure hose to a low-pressure sprinkler system.
You are. The inflamed airway mucosa is now incredibly friable, delicate tissue, and it is absolutely engorged with this high-pressure arterial blood. When the patient experiences an exacerbation, they cough violently, repeatedly, trying to clear those stagnant, sticky mucus pools. The sheer mechanical force of that violent coughing ruptures these hypertrophied, fragile, high-pressure vessels right into the open airway.
Oh my God.
This leads to sudden, massive, and potentially life-threatening hemoptysis. The bleeding can flood the remaining healthy lungs and cause asphyxiation.
It's the body's own inflammatory healing response, creating a vascular time bomb.
It is a devastating complication.
When we try to quantify this destruction, we turn to high-resolution computed tomography, HRCT, which is the absolute gold standard for diagnosing bronchiectasis. Pathologists and radiologists use Reed subtype to visually classify the severity of the architectural damage. Let's paint a visual picture of these three stages.
Dr. Lynn Reed described three distinct morphological classifications based on exactly how deformed the bronchia become. The first and mildest form is cylindrical bronchiectasis.
How does that appear on the scan?
The involved bronchi appear uniformly, perfectly dilated, like straight, rigid pipes instead of gently tapering branches. Crucially, they end abruptly, squaring off exactly at the point where the smaller, distal airways are completely plugged solid by thick secretions and scar tissue. When a radiologist looks at a cross-section of these parallel, thick-walled, dilated airways on an HRCT, it creates the classic tram line appearance.
Tram lines, like a train track.
It looks exactly like a set of parallel railroad tracks running out to the edge of the lung.
The next step up in structural severity is varicose bronchiectasis.
As the elastase continues to chew through the airway wall unevenly, the bronchi lose that uniform cylindrical shape. They develop a highly irregular undulating pattern. You see areas of balloon-like dilatation alternating with areas of tight, fibrous constriction.
It visually resembles varicose veins in the legs.
It perfectly mimics them. On a
Mm.
CT scan, it literally looks like a beaded necklace strung through the lung tissue.
And the final, most severe end-stage form.
Saccular or cystic bronchiectasis. In its terminal stage of the disease process, the structural integrity is completely obliterated. The bronchi balloon outward at the periphery into large, blind, fluid-filled sacs. There are absolutely no recognizable bronchial structures distal to these sacs. The peripheral lung parenchyma is entirely destroyed.
There is a very famous radiological sign associated with this stage.
The signet ring sign. Because the bronchus is so massively dilated, when the CT scanner takes a cross-sectional slice through it, the huge, thick-walled airway looks like the large circular band of a ring. And sitting right next to it is its accompanying pulmonary artery, which appears as a much smaller, dense white dot.
I see.
Together, the huge airway and the small artery look exactly like a ring with a jewel set into it. When you see multiple signet rings, you are looking at profoundly destroyed lung tissue.
It is a devastating radiological progression. Let's transition into the clinical management masterclass. When an adult patient with advanced bronchiectasis walks into your clinic, what is the clinical picture?
The absolute hallmark of the disease is a chronic, persistent, or recurrent cough, accompanied by the production of voluminous amounts of highly purulent, foul-smelling sputum. They're coughing up cups of this material every day. The patient is engaged in a constant, exhausting battle to clear those stagnant pools of infected mucus.
And hemoptysis, as we explored, is common.
It occurs in 50 to 70% of advanced cases, ranging from blood-streaked sputum to a massive acute hemorrhage. Furthermore, these patients carry a heady systemic burden. They often look profoundly chronically ill. Systemic symptoms are ubiquitous: profound fatigue, significant unintentional weight loss, and severe myalgias.
Just from fighting the infection.
They are burning a tremendous amount of metabolic energy simply fighting a chronic, smoldering bacterial infection 24 hours a day, alongside the immense caloric cost of their increased work of breathing. Dyspnea on exertion and chronic wheezing are standard.
When you put your stethoscope on their chest, you must hear a chaotic acoustic picture.
It is a symphony of end-stage pathology. A thorough physical examination will reveal a mix of crackles caused by air popping through the fluid-filled sacs, low-pitched rhonchae from the thick mucus violently rattling in the large, dilated central airways, and high-pitched wheezes resulting from the fibrous narrowing and scarring of the surrounding airways. Furthermore, due to the chronic hypoxia, you will frequently observe significant digital clubbing, a bulbous swelling of the fingertips.
The disease course isn't steady, though. They have baseline symptoms, but they are prone to acute exacerbations.
An exacerbation represents a failure of the baseline equilibrium. It is usually precipitated by the acquisition of a new viral infection or a massive overgrowth of their colonizing bacteria. Clinically, an exacerbation is defined by a sudden, severe increase in both the volume and the purulence, the thickness and green color of their sputum. They will experience an alarming increase in hemoptysis, worsening breathlessness, and the onset of systemic fever and chills.
For diagnostics, we established that the HRCT is the gold standard for defining the structural damage. But a thorough clinician doesn't just treat the dilated airways. They must hunt relentlessly for the root cause of the bronchiectasis. We need to know exactly why the vicious cycle started.
That is the cornerstone of management. You must perform comprehensive sputum MCS microscopy, culture, and sensitivity frequently. You need to know exactly which strains of Pseudomonas, Haemophilus, or Staphylococcus are colonizing the lungs, and critically, you need to know exactly which antibiotics those specific biofilms are sensitive or resistant to.
What other specific tests are mandatory in the workup?
We utilize gene expert testing on the sputum. This is a rapid molecular diagnostic test, specifically hunting for the DNA of Mycobacterium tuberculosis, as well as determining its resistance to rifampicin. Missing a TB diagnosis in a bronchiectasis patient is a catastrophic clinical failure.
And we must hunt for those underlying genetic and immunological defects we discussed earlier.
Absolutely. Regardless of age, we check sweat chloride levels to definitively rule in or rule out an atypical presentation of cystic fibrosis. We also perform a rigorous quantitative assessment of their immunoglobulins, IgG, IgA, IgM, to determine if a hidden immunodeficiency is the reason they continually fail to clear respiratory infections. Finally, regular pulmonary function tests, or PFTs, are vital. They will demonstrate a classic obstructive pattern, a reduced FEV1, allowing us to objectively quantify the extent of the airflow obstruction and track their decline over years.
Okay, let's dive into the treatment protocol. How do we slow down a cycle that is actively destroying the lung?
The clinical management of bronchiectasis rests on three core pillars. One, the aggressive targeted treatment of bacterial infection, particularly attacking acute exacerbations. Two, the physical mechanical improvement of the clearance of tracheobronchial secretions. And three, the reduction of the underlying hyperinflammation.
Let's start with the antibiotics, which are the absolute cornerstone of halting the elastase destruction.
Here's a crucial point regarding antibiotic stewardship. Systemic antibiotics are generally reserved exclusively for acute exacerbations. We do not keep these patients on continuous oral antibiotics because that is a guaranteed recipe for breeding multi-drug-resistant superbugs in their lungs. The choice of antibiotics should always be precisely guided by their most recent gram stain and sputum culture sensitivities.
However, when a patient presents in acute distress, you can't wait 48 hours for a culture to grow. You need empiric coverage immediately. What are we reaching for?
Empirically, we target the most likely culprits, Haemophilus influenza, Streptococcus pneumonia, and Moraxella catarrhalis. We often initiate therapy with high-dose amoxicillin, cotrimoxazole, or a respiratory fluoroquinolone like levofloxacin. But for significant, purulent exacerbations, clinical data supports a very specific, aggressive dosage regimen. Amoxicillin clavulanic acid administered at exactly 22.5 milligrams per kilogram per dose, given twice daily.
Let me repeat that for the listeners, just to be crystal clear. Amoxicillin clavulanic acid, 22.5 milligrams per kilogram per dose, twice daily. Why such a specific, robust dose?
Because you are fighting an uphill battle against altered pharmacokinetics. You're trying to force a water-soluble antibiotic to penetrate deeply into thick, avascular scar tissue, punch through a highly resistant bacterial biofilm, and achieve therapeutic concentrations inside a stagnant pool of mucus. A standard sinusitis dose will fail completely. The 22.5 millikilojoules dose twice-daily regimen provides the sustained peak concentrations necessary to crack the biofilm and suppress the bacterial load.
And if they present with a massive exacerbation, perhaps driven by Pseudomonas.
And oral antibiotics are entirely insufficient. The patient requires hospital admission and 2 to 4 weeks of aggressive parenteral intravenous antibiotics, often utilizing 2 different classes of anti-pseudomonal drugs to adequately manage the acute flare. In highly selected cases where patients have constant, unrelenting exacerbations, we might employ long-term prophylactic macrolides like azithromycin, not necessarily for their antibiotic effect, but because macrolides uniquely possess potent anti-inflammatory properties that calm the neutrophil cascade. We also increasingly utilize nebulized antibiotics like tobramycin, colistin, or estrionam.
Nebulizing the antibiotic delivers it directly to the site of the infection, bypassing the bloodstream.
Precisely. It allows us to achieve astronomically high concentrations of the drug directly inside the airway lumen, right on top of the biofilm, while minimizing systemic toxicity to the kidneys and ears.
That aggressively handles the microbiology. But we established that the fundamental physical problem is mechanical. How do we physically extract that thick, tenacious, cement-like mucus out of damaged, floppy tubes that have no functioning cilia to sweep it up?
It requires daily, grueling commitment from the patient. Chest physiotherapy and postural drainage are non-negotiable. The patient must assume specific physical positions that use gravity to drain different lung segments, combined with mechanical percussion clapping on the chest or wearing an oscillating vest to physically shear the mucus off the bronchial walls. Gravity has to do the work the cilia no longer can.
But percussion alone won't move cement. We have to change the rheology, the physical consistency of the mucus itself.
That is where advanced airway hydration comes in. We prescribe inhaled hypertonic saline, typically a 6% or 7% concentration, or inhaled dry powder mannitol.
Explain the physics of how inhaling salt helps you cough.
It's pure osmosis. When you nebulize hypertonic saline into the airway, you deposit a heavy concentration of salt onto the surface of the thick mucus. Nature seeks equilibrium. The high salt concentration acts like a sponge, rapidly drawing water out of the airway cells and into the airway lumen. This influx of water dramatically rehydrates the mucus, breaking its desulfide bonds, thinning it out, and making it vastly easier to mobilize and cough up during physiotherapy. Rigorous adherence to this hydration protocol has been shown to drastically reduce exacerbations and significantly improve the quality of life in adults with bronchiectasis.
And obviously, any underlying disorder that is constantly feeding the fire, like an immunodeficiency requiring IVH infusions or chronic aspiration requiring swallowing therapy, must be aggressively addressed simultaneously.
Absolutely. You must treat the underlying driver or the cycle will never stop.
Finally, we have to discuss the endgame. What are the end-stage options when the aggressive antibiotics, the hypertonic saline, and the daily chest physiotherapy are no longer enough to outpace the elastase destruction?
When the architectural destruction becomes too vast and the medical management fails, we must turn to surgical interventions. If a patient is suffering from massive, recurrent, life-threatening hemoptysis, the first line is bronchial artery embolization. An interventional radiologist threads a catheter up from the groin, navigates into those hypertrophied, bleeding bronchial arteries we discussed, and deploys coils or particles to physically block the blood flow and stop the hemorrhage.
And if the bleeding persists or the lung is completely destroyed?
Then surgical resection, removing the completely destroyed bleeding or chronically infected lobe, is required, assuming that the patient has enough healthy lung tissue remaining to survive the operation.
And for total bilateral respiratory failure?
If the bronchiectasis is diffuse, affecting both lungs, and the structural damage is so profound that the patient's FEV1 forced expiratory volume in 1 second drops persistently below 30% of their predicted value, they are in end-stage respiratory failure. At that point, they enter the incredibly narrow, complex window where single or double lung transplantation is evaluated as a final life-saving measure to replace the destroyed organ entirely.
What an immense, sobering journey. We have traced the pathophysiology of the breath from a newborn taking their first obstructed gasp in the delivery room, relying entirely on a clinician's ability to decipher the exact pitch and mechanical timing of a stridor to save their life, all the way to the chronic, relentless, decades-long cycle of bronchiectasis requiring a double lung transplant in adulthood.
It truly underscores the profound gravity of our profession. It highlights how crucial early, accurate diagnosis is. The ability to differentiate a benign floppy supraglottis from a pure central malacia where administering a standard albuterol inhaler could cause catastrophic airway collapse is not just textbook knowledge. It dictates life-saving clinical care.
We have meticulously covered the membranous blockages of choanal atresia, the precise surgical grafting required for subglottic stenosis, the rogue, high-pressure hemodynamics of a pulmonary sequestration, and the relentless, elastase-driven, vicious cycle of structural destruction.
As we close this deep dive, I want to leave you with a profound physiological concept to ponder, one that is rooted deeply in every single pathology we've discussed today. The human respiratory tract is, in essence, a masterclass in the butterfly effect.
How so? Connect those dots for us.
Consider the embryology we explored. A microscopic error occurring on exactly the 35th day of gestation. A tiny signaling failure among a few cells dictates whether a lung lobe develops into a beautiful, functional network of alveoli or whether it becomes a dysplastic, disorganized CPAM mass harboring malignant, sarcomatous potential decades later. Or consider a single, undetected foreign body, perhaps a small plastic bead, resting quietly in a child's right lower bronchus.
It seems so impossibly small compared to the whole patient.
But that single, localized event triggers a relentless inflammatory cascade. It summons the neutrophils. It fundamentally alters the architectural integrity of the lung forever. It literally turns the body's own defense system, specifically the patient's own neutrophil elastase, into the very mechanism that digests, liquefies, and destroys the airway, culminating in the untreatable, dilated signet ring sacs of severe bronchiectasis. It challenges us as clinicians to view the simple act of breathing not merely as a repetitive, guaranteed physiological function, but as an ongoing, highly precarious structural balancing act.
A balancing act where every single detail, from the first day of fetal development to the exact concentration of a nebulized salt solution, intimately matters. Thank you for joining us on this deep dive.